the video. Yeah. If you remembered all that from that video, can I borrow the video?
Yeah. Well, good news is this is all in video today. So thank you. You guys, can you give a thank you to Chris for being here all day? And if you think you're bored, think how he must feel.
He is 8 and he has liquid in his cup.
So
he's doing great.
Wow.
Yes.
All right.
Clear.
Let's move on so we can wrap this up, do integumentary and some things and anything else. So good job. Who wants to start? And Caitlin, are you going to be our scribe? So you can see somebody else's writing besides mine for a change? All right.
You're just reading to her.
Oh, sweet.
Yeah, she's going to scribe for you, but go ahead and talk about your topic.
He's a different one. He's seizure.
Seizure.
Yeah, seizures.
I was like,
Oh, you're taller than I am too. You can actually reach up there.
All right, I don't know who I should.
So, actually, Chris, I'm going to move this microphone around. Let's put that on you so that we can hear. I'll do that. Oh, Jesus, I'm sorry.
It's all good.
I shouldn't. Can't trust me. That's why we can't have nice things.
Thank you.
Okay.
Hopefully, I don't talk too loud.
Okay, good.
All right, sweet. All right, so seizures. Wow, now I'm thrown off. So we have these different types of seizures. We have myoclonic, and that's oh geez. 688 through 689. Well, it's only on 688 for seizures. Yep. Thank you. And with that, you'll get brief muscle jerks. So keyword on that is brief. And then we got tonic. And I'll give you time to write it out. Yeah, I'm going to be super awkward, just saying.
yeah, awkward.
So stiff, like sudden stiffness of the muscle for tonic. Then we got clonic. So that's going to be rhythmic jerking.
That's right.
Yeah, you got it. Then we have atonic.
Atonic?
Mm-hmm. Oh, I skipped one. So that's going to be a sudden decrease in muscle tone. Then we have absence, which is you pretty much just blank out for a few seconds. So I guess we all kind of have that. It's more common in children. And then there's tonic, clonic. Yep. And it's just literally a mixture of tonic and clonic.
It's both, just both.
At the same time, yeah. All right, so things to look out for as well. You'll see that they'll have any convulsions. You'll see they'll have muscle rigidities, loss of consciousness, a lot of jerking movements, and a decrease in muscle tone.
So pretty, Caitlin.
That is actually very nice. So this is what you want to do if you see those seizures, those symptoms. You want to monitor the respiratory rate. You write fast too. You want to make sure that the airways stays patent. Yeah. And you want to turn their head to the side. And the reason why you want to turn their head to the side is just in case they choke and drown in their own vomit. You don't want that. Make sure you put them in a nice, safe location so they're not bumping into things that may fall on top of them that are pretty heavy, or they just hurt themselves even more. And position them without constraint. You don't want to have them feel super closed in. Want to give them some freedom. And that's pretty much it for seizures.
And to respect their privacy, that's why you put them in what you call a spot.
In a safe location.
To respect their privacy.
Okay. And yeah, we can put in respect their privacy.
Maybe it's moving other people out of the room. You can't move them.
Okay.
For some reason, I always thought you didn't turn your head. You turn your head. I don't know why I thought that. I mix it up. Huh?
You don't put the spoon in the mouth. That's the misconception. People say like put a spoon in the mouth so they don't choke on the tongue.
Mhm.
But that was just.
Oh, I don't think I've heard that. Got it. Okay.
Yeah.
Okay. I feel like I'm confusing it with something else.
Well, that's what the book said.
Makes sense.
Yeah.
I believe you, Stephen.
All right. Any questions? Sweet. Awesome.
Good. That's a good review.
Thank you.
Thanks. Thank you, Stephen.
All right, who's up? Okay.
It'd be bad if I brought this over
Hand it back to your.
there. Sweet.
Flip it back on.
Oh, Jesus. You see, I think that's just a curse at this point. And the whole thing came on.
Steven.
That's so weird. I'm just gonna boom. That's
the
it.
black on black shirt is hard to see.
Oh, that was funny.
Thank you. I feel so much better now that I'm not. We can be
It
more
was
on
even worse when I knocked his clipboard off. No, I hope not.
Monitor
Yeah, allergy reactions.
I'm such a slow writer.
So we found ours on page 386. And this is what made it a big difference when it comes to mild and moderate. You're going to see a lot of itchiness, watery eyes, skin is going to be red. We also said wheezing, hives, swelling.
Did you say 386?
Yes.
Oh, they might have. Is that your book, Trey?
No, that's my book. Oh, my bad.
686.
686. My bad, guys. 686. 686. You know, the numbers were right. It was just different order.
Is that 686 for the people in the back?
Yeah, 686.
Thanks.
And then the common allergies that we usually see as well is usually soy, dairy, eggs, shellfish.
As well as latex.
Yeah. Even getting bites from insects as well. That's another one too. And pollen.
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 Respect.
Hey, no, it's
People from Poland.
sorry guys, it's my accent.
TheraBand is latex. So you have to make sure someone doesn't have a latex allergy
Mhm.
and hand them TheraBand to exercise with.
So now this is where it gets a little tricky. If it's severe, that's when we definitely have to take things in consideration. Where if it's severe, the patient might have their own EpiPen, and with that EpiPen, we could actually help them assist them.
If they're going through a reaction.
We could either help out with the ingest or the injection of the medication. But
if
that,
they have I'm sorry.
Yeah,
If
go
they
ahead.
have a throat closing type of reaction, then you're not supposed to give it to them orally.
Mhm.
So
That-
what do you mean? Then you give them the.
Yeah.
Okay.
If they have, but they're still having a hard time breathing still, regardless anyway, we still got to call the ambulance.
Okay.
And that was pretty much straightforward for when it came to allergy reactions.
Any questions? No. Thank you for your time.
Thank you. Who's next?
So, can you think of how this could pop up in the therapy clinic?
Well, as of today, like we're having a potluck, if someone could eat something that they didn't know that there was, for example, nuts in, that they could have an allergic reaction to the nuts, so they could start breaking out in their face. Also, if they have a like a skin rash or something like that, you can give them some calamine lotion. Oh, excuse me. You want to start off by washing the affected area with a mild soap with some warm water, and then you want to apply hydrocodone cream as well as calamine lotion, and then end it off with a cold compress. That should
Hydrocortisone.
what I said.
Hydrocodone.
Hydrocortisone cream, and then finish it off with calamine lotion as well as a cold compress.
Now, if you're in a medical facility, that would be deferred to the nurse. You need a doctor's order to put anything on that's medical.
Yeah.
Mhm.
But the emergency response, obviously, until you can get the nurse down there.
My first clinical, the rehab tech gave a patient the TheraBands when she was latex free, and it said it really big on her chart. And the lady came back the next day, and she's like, "I have all this stuff. My hands are incredibly itchy." And we're like, "No, you're not using the latex."
That was for
Or freely.
skin rashes.
Is it cold water?
Cold compress. Warm water for washing.
I don't want to drop it.
And then end it off with a cold compress.
Maybe just hold it.
Cherish it. Cherish.
Allergies can pop up out of nowhere. I'm like, I was ready.
Our paces are on. Okay, I'm just gonna pass it to you. I can't read that. You're gonna talk. I'll talk.
It's a mild moderate. We just let the PT know what was going on, but
Yeah, I think it's
very
more
severe.
respiratory. So while we're looking at that one, you want to do blood sugar next?
Yeah.
It's kind of in the same family of.
Okay, so most of our stuff is on page 470 and 471. So we have the oral glucose tolerance test. It's on the bottom of 471. So you can drink a sugary drink, wait 2 hours. It's positive for diabetes if it's around 200 milligrams. And then normal pressure is less than, or reading is less than 140. Hyperglycemic or glycemia is more than 180 to 200. It can increase your thirst. You can end up having to urinate a lot. If you have diabetes 1, you can get ketoacidosis, which is acid buildup in the blood. You can get it for 2, but it's not as common. It's more rare. Hypoglycemia is less than 70. For the reading, includes hunger, sweating, shaking, dizziness. You want to look out for signs of exercise, including induced for hypo. I don't know which one. Hypo what? Hypoglycemia. Yeah. Hypoglycemia. With strenuous or prolonged exercises. And you can ask them if they want like a carbohydrate like snack or something. You want to ask the patient, did you have lunch today? Or depending on what time it is that you met them. Carrie Mara has more to add.
Okay. So, you okay, Caitlin?
Yep.
Sorry. I get nervous when I talk fast.
So yeah, with the exercise response, whenever you exercise, it'll decrease their strength, their stress, not their strength. That'd be terrible. Their stress, and basically the blood glucose uptake by the muscles is what's increasing there, which is why the hypoglycemia comes in. So with blood sugar, you got 2 different types of diabetes. You got type 1, which is the pancreas fails to produce insulin, most common in children. And that's where the ketoacidosis comes in. I'm going to give her a second. I don't write that fast at all, so I'd be so behind. Cool. Type 2, basically, it has endogenous insulin retention, and it happens with people usually 45 or older. And the ketoacidosis is rare.
What was endogenous what?
Insulin retention.
Keto, what are you saying?
Ketoacidosis. Sorry.
Okay,
I keep saying.
Acid buildup in the blood.
Yes.
Okay.
So then last thing, considerations that you have to go ahead and take with people with low blood sugar and with diabetes is obviously peripheral neuropathy and their wound healing. And for that, you want to go ahead and make sure to check their skin and what shoes they're wearing. Yeah. And you want to make sure you have consistent manage of their insulin and their diet and exercise. And just make sure of any changes basically, because if you're hypo, you will get dizzy, so you have to make sure of the patient response of what's happening throughout the whole time. And yeah, that's it. Woo.
What's the necessity? Blah, blah, blah. I just had a whole stroke. What's the necessity to look at their shoes?
The peripheral neuropathy and their
Because when
wound
you're
care.
diabetic, you can get peripheral
So you
neuropathy.
look at their
You want to look at your feet to make sure they don't have cuts, bruises, or anything, but have good shoes. Make sure they're wearing good shoes.
okay.
And that there aren't keys in the golf shoes.
Thanks, Karen.
Yeah.
So real quick, did you guys mention the actual signs and symptoms of hyper versus hypo? Because sometimes in diabetic,
Yes.
you're not really sure which side you're on.
With-
you're acting funky.
With hyper, you get increased thirst, increased urination, and the ketoacidosis. And with hypo, you get hunger, sweaty, and dizziness.
Okay, so if you think about when you're hangry,
Shaking and dizzy
the
too.
person who's got low sugar is acting hangry. They might be irritable, and that. The person who has high sugar still might have some similar symptoms, but we talked about that fruity breath. So
Oh,
we
yeah.
have to know: do I give sugar or don't I give sugar? And so who would be more confused, the hyper or the hypo? Who would actually be confused? You have confusion on that? Okay, the hypo confused.
Yes.
And then because if you're hyper, you don't want to give them sugar.
Mm-mm.
You also don't want them going in a coma because their sugar's 12 and you should have just gone ahead and given it. When you do give sugar, you give 4 grams of sugar. No, 15 grams of sugar at 4 calories a piece. So about 60 calories of sugar. It could be 4 ounces of orange juice. It could be, if they're alert, they can start sucking on some hard candy. They probably bring some sugar pills with them. But it's 15 grams of sugar, which is about 60 calories. So keep one of those little hospital juices on hand in the refrigerator. You don't have them chew something like an apple. They need it faster than that. So if their sugar is well low, like 50, 40, and like you mentioned, when they're exercising, their sugar will continue to drop. So during exercise, blood sugar drops. Okay?
So is it better for a liquid for them to?
Yes.
Okay.
Yes. Or a sugar pill that they brought that they keep like.
Okay.
In case of that. When would their sugar typically be too low? When they've had an insulin shot that day, but they haven't eaten. Or maybe they've had the flu and they've been vomiting and they haven't been retaining a lot of intake. Or it's right before lunch and they haven't eaten in 4 hours. That's not the best time to do aerobic exercise. So they should check their sugar before they exercise. If it's under 100, they should probably eat something before they exercise. Okay? You just know the difference between hyper and hypo as far as an emergency response. Like something's going on, but if you had to err, if they're already at 500 sugar, you give them another 15 grams, that's not going to put them over the top. But if they're at 30 grams of sugar and they're about to pass out, you've lost the window to give them anything. If they're unconscious, you can't give them anything. So, okay? All right.
Got it.
All right. You want to do CPR?
Sure. Oh, you're gonna hold it.
Don't tap on it. It's gonna be loud.
Hello, can you hear me? So we did CPR and first aid. So what we'll talk about first is CPR. So you might want to erase first aid because it's gonna be a lot.
You can erase the schedule if you need to then.
So first we want to discuss, obviously you're going to scan the area and see if they need the CPR. Once you establish that they need CPR, you're going to think of your favorite song, which is going to be Staying Alive. Your compression rate is going to be 100 to 120 compressions per minute. And then your compression depth for adults is going to be at least 2 inches. For children, it's going to be at least 1/3 anterior posterior depth, which is about 2 inches. Your hand placement for adults is going to be the heel of your hand on top of the other, and then pressure over lower half of sternum. And for children, it's going to be the same. Over lower half of sternum. Sorry. For children, it's the same as adults. For infants, you're going to use your 2 fingers with pressure over the sternum just below the intermammary line. Mammary.
Is there a difference between using 2 fingers versus using your 2 thumbs?
Oh, that's a good question.
I was taught you could do either. Yeah.
Depending on how you get them positioned.
Yeah. Because fingers, you have to be able to go like this.
You do the 2, but if you have 2 people present, you do from the side or from the side. That's what I was taught.
In the book, it doesn't disclose, which is better. So, for the airway, you want to do a head tilt with a chin lift. If trauma is suspected, you want to do a jaw thrust. And then on here, I don't know if they still do air with compression, but for the sake of the book, ventilation is 1 second per breath with visible chest rise. And your compression to ventilation ratio for adult is 30 to 2. And then for children, it's also 30 to 2 if you have 1 rescuer. If you have 2 rescuers, it's 15 to 2. And then if all else fails, you grab the AED machine and let it talk you through it.
And when you identify that somebody needs CPR, you of course want to call 911 and have EMS on their way to keep them going as much as they can until superheroes come. And then when you identify someone has an obstructive airway, they obviously won't be able to tell you. They'll be grabbing at their throat, having a hard time breathing. That's when you want to perform the Heimlich maneuver. Bear hugging them from behind. You want to drive the knuckle into the bottom of sternum, drive in and up to help clear the airway.
Hopefully.
That's the idea.
Forcefully.
What page do you guys say?
Sorry.
688 and 689.
Any important information?
All right, what's the down and dirty on first aid response?
Down and dirty, you want to clear the area. You want to avoid infection, so you want to clean the wound, preferably with peroxide solution. If there's bleeding, you want to apply moderate pressure. And then, in case of emergency, call 911.
Rich, what do we have left?
DVT.
Blood clots.
Are you blood clots?
Hand dead yet?
Yeah.
Are you guys doing blood clots?
You all planning on just taking a picture of that? And then
Yeah, because I can't write all that.
You want me to do it?
Yeah, you want to. I'll write it after. Her page is a little different from mine. So it was page, a couple pages, 137, page 270, and 366.
366. Yeah. Okay. So basically, a DVT, I'm going to write this after I'm done, is an embolism that's discharged and blocks an artery. They usually, you said that on the lateral side, they usually occur on?
Yeah, where you see it.
So SCIs increase the risk of DVTs. Heparin decreases. It's an anticoagulant. It tries to break up the clots before they discharge and get somewhere else. Symptoms of it can be lower extremity swelling, pain, sensitivity over the area of the clot, and then warmth within the area of the clot. And then when you do suspect a blood clot or a DVT, you don't want to do active or passive range of motion to the involved lower extremity. And usually when they have that, they get prescribed bed rest, anticoagulants. They could get surgery. One you can get is a filter in the vena cava to filter out blood clots so they don't get into your heart and cause a myocardial infarction. And then usually preventative measures once they've discovered a DVT include anticoagulants, a positioning schedule to keep you moving, range of motion, and then elastic stockings if you need them. Specifically for myocardial infarctions, their blood flow gets blocked in the coronary artery from a blood clot, and it usually causes a heart attack or myocardial infarction. Basically, the blood flow in your heart's getting stopped. So, with pulmonary embolisms, they're the most common cause of blood clots in the lower extremities is a pulmonary embolism, and they get caught in the arteries in your lungs and cause a. It's pretty self-explanatory. And then cerebral vascular accidents are usually rapid with no warning at all. You usually have a headache, and then you have a cerebral vascular accident, a stroke. And then they travel through the bloodstream to the cerebral arteries. That's the basics of DVTs.
What's the test that will be done to determine if a patient has a DVT?
Yeah.
Home sign you can do. It doesn't have great predictability. A lot of false positives and negatives. What's going to be happening in the radiology department? What can they do?
Can't they do like not blood scans, but
Doppler.
That what I'm thinking of.
Ultrasound. They'll check. Run the ultrasound over that and tell if it's locked in the popliteal area down to the veins. So it's in a vein because that's what the V is for. But it breaks loose.
And travels to the arteries.
DVT, you die when the blood clot moves somewhere else. Yeah. So it's that sudden shortness of breath is a sign of a PE, pulmonary embolism. Sudden shortness of breath on someone who shouldn't have shortness of breath.
That's when it breaks loose.
That's when it's lodged in the lung, and that can kill you.
Yeah.
If it lodges in a cerebral artery, as you mentioned, that becomes a stroke. So everything past that artery that was supposed to be getting blood delivery with oxygen isn't getting it, and so that part of the brain dies. And then if it's in the coronary arteries, any part of the heart that was supposed to receive blood flow from that branch of the artery gets starve of oxygen. So that at first that's the angina, chest pain, and all that. And so if they can get that reversed, it can heal. But otherwise, that part of the heart now is pretty overcooked state. You know, it's not going to be contracting.
So, question. So, my husband's mom had some like breathing issues. She went up to her car because she said she couldn't breathe, so she wanted like the air from the car to like blow on her. And then by the time the ambulance got to her, they already pronounced her dead. So we were thinking that
It's probably a heat.
because it was pretty quick.
Had she been recently bedbound or had surgery or anything?
We didn't really, not bedbound, but she was going to the Moffitt clinic or something.
If she had had some reason that she had blood clots. It could be a piece of it.
And it's like a lot of times in women too, like it's like shoulder pain and back pain, and we just kind of blow it off, and that could have been it the whole time too.
You're saying this is for pulmonary? You think it was
That's
pulmonary?
what
So the blood clot anywhere could have, that's where it landed. It can be that quick. Our first clinicals out in my PT class, we had just 2 weeks. You go somewhere, don't kill anyone, like after your first couple months of therapy school. And unfortunately, when we came back, one of our classmates' patient had died from a PE, walking around the clinic, right at the hospital. I don't feel good, sat down, called the nurse, and unfortunately she passed away. It's not a good way to start your PT education.
Yeah, no, I'd be like, I'm out.
Yeah.
I'm done for the day.
So how she was saying, like they can cause
Just like when you're having a heart attack.
That would be
Is that
myocardial.
Yeah,
that's for
myocardial.
myocardial.
Yeah,
It's shoulder and
shoulder
back.
back and women.
Okay.
Yeah,
Yeah, they have very misleading
Yeah.
cardiac pain.
That patient died in the same day or right after that treatment?
In the therapy clinic, in the therapy department. They didn't make it back to the unit. So again, so you have someone who's just a surgical patient, and like out of nowhere, like, oh, I'm really short of breath. Run their butt, get them up, call the doctor, I wouldn't call it code because they're still conscious, but like you need to be like, we need to get this patient.
You said fast, I'm thinking like within a week.
No, like in 10
like
minutes.
moments.
So what are the signs that you look for?
Sudden shortness of breath.
That's it?
Yeah.
But that could be anything.
So like, again, if I had a knee replacement, I shouldn't just somewhere, you started stretching and then I'm doing some walking, I'm going over the new stuff. You shouldn't suddenly become like short of breath.
Sweating.
You know what I mean? Like, I should have muscle fatigue. I shouldn't become so short of breath. They're very aggressive now in the hospital because of this. So my mother was recently in the hospital for cardiac incident, and she had shots of heparin in her belly they were really going after this blood thinning thing. It's a little frustrating because that's a lot of poking and she had too much poking, and I thought, well, where's the EPK piece cost? Why couldn't they be doing the cath pump on here and all that? They said, oh no, we do the shots now. Like, that's a pretty aggressive anti-embolism protocol to just be shooting them up with thinners. What about a Coumadin pill? Could we try something, without, they're just poking her everywhere. But yeah, it's pretty important. It's pretty important. Okay, how is that as far as a safety recap? That was pretty good, you guys. See, you can dig in and find this stuff. We have only 45 minutes left, and what I want to cover is integumentary and just a few terms on research and evidence-based practice. So some things you don't need to miss. So if you want to take,
You're done, Caitlin.
yeah, if you want to take, and I won't have to erase that because I'll just talk you through if you want to leave that up there. So yeah, come get your picture. We'll wait till she's done.
I don't want to be a big old pause that for 5 minutes and then I will die.
Thank you for doing that.
We appreciate your
There's so much appreciation.
Yeah. Thanks, Jackie. We appreciate you. Because Jackie just walked out.
I know. I've done the same thing. I think I've called Jackie too.
I used to work at a restaurant and everyone thought I was another girl. And the only thing we had alike was our hair was the same, almost the same color and the same length. That was it. We looked nothing alike.
Oh shoot, I did not want that from the beginning. What am I doing? I was on like slide 100. Well, I said 100. It's 244 slides of burn care, but I wanted to give you this.
I have birds on my list this year, but I was wondering if you do it. Okay, it's done. Thank you.
Do you have one extra integumentary handout that I can look at? Thank you.
Yes. You may flip through your slides when you
Thanks.
talk or something.
That one I actually did here.
No, I've got. I just need to get it to show up now. I need to say from current slide.
And pull them. That pull one.
Hey, Caitlin, when you're ready.
Look, find it now.
And your tongue. You're like your tongue.
Oh, I did that when I spoke. I didn't know I did that one. I didn't know if they were really concentrating. I just
That's not.
Sometimes if I don't have the slide on, it doesn't find it and it wants me to close the slide and then reactivate the flash. So let me try. Or I can maybe do the F8 or something.
Pull it out, put it back in.
Usually, if I don't know, that's just display settings. Okay. Then I just have to drag it again, right? Oh, I have to exit full screen, I think.
You can make it full screen again once you do.
Let me see which slide I want.
It's a lot more than I thought it was.
Okay, so this is slide 57. There we go. Okay. Is everybody back? We're in the final stretch here. 2, 4, 6, 7. Okay, so after a few years of analyzing student outcomes on this licensing exam, I noticed that for some reason students were really struggling in the integumentary system, and there were only about 7 questions. But I mean, you look at the results, and then you're like, integumentary was way down here. I'm like, what in the heck? And then in the last version of the test, they beefed up integumentary and lymph system as separate. So there's even more questions that could involve the integumentary and edema and all that stuff. So I put together this extra sheet for the last couple years just to make sure we can capture all this on one sheet, okay? So in our area in Ohio, there is a burn center that is like world-class burn center. And so I, knowing one of the therapists that had been there for 30 some years, we were always blessed with her 4-hour lecture on burns, which, she's retired from doing this now, but I still have her slides. But I do want to just make sure we can classify wounds and burns, okay, in depth, and talk about basics of wound closure and a couple things that I pulled. The back sheet comes right from the content outline from the test. And this is how it's described, things that you need to know about the system. So let's look at the chart side. I just want to make sure you know the term intention. Have you heard of that? Primary intention? That's closing a wound by surgical means. That would also include a skin graft for a burn. That's primary intention. Okay? All right. Obviously, you want to get things closed quickly. Secondary intention is when things heal on their own, right? Through epithelialization. That should sound familiar. The problem with that is if it's a large wound or burn, you're going to have scarring, right? So that's the decision maker, whether or not the doctor chooses to do surgical closure. Let's say you're in a motorcycle accident and, you know, half the skin on your back is ripped open and they're like, well, are we going to close this with a skin graft? Or what are we going to do with this? Well, first, you can't close anything that's dirty and infected. So they have to leave that thing open and get it cleaned out. You need completely pink red granulation tissue. So you got to get all that other stuff out. So secondary intention is where you let it heal on its own. We know that a wound heals from the bottom up and the sides in. That's called contraction. And the deeper it is, the more chances that it could cover up the top like a solar cover on a pool and not really be healed from the bottom. And now you've just closed in a complete infection and it's going to burst out one of these days and you're going to find out that there's tunneling and everything else. So it has to heal slowly up and out. Okay? You might do that for just a partial thickness burn or small, you know, ulcers. Tertiary is you add the two together. You let it heal a little bit, and when it's clean and ready to go, then you close it up. Okay? I just want to make sure you know those terminologies. That's something that they'll do with an infected wound to get it cleared out. You want to see a burn wound, scapula, motorcycle? Okay.
Yes.
All right, so this one is, obviously this is the left scapula. So the important part of this is the whole part of the wound is going to have different depths. It's not just one. So this is obviously where the scapula was deepest burned from, like the exhaust or whatever that they came in contact with. The rest of this has all been left open to clean look how red and beautiful that looks now. So it's going to be ready for closure. Around the edge, it's already started healing in the amount of time, you know, that they've been hospitalized. Okay. So obviously that's going to be closed with a skin graft. The skin graft has to come. What's that?
Maybe she should have been wearing.
Yeah, perhaps.
She was probably one of the ones that you see on the bikes with like.
I need to get to your skin depths here. All right, let me get to your skin depths. You know the difference between chemical burns and electrical burns, right? Electrical burns have an in point and an out exit point, right? They follow the water. Okay. Let's get to the depths. Okay, hold on one second. I have to.
Amber, I'm gonna come to graduation on my bike. Your motorcycle? Yeah. Or your bicycle? My motorcycle. No. My
Okay.
dad has a sidecar. He keeps a stuffed monkey in it.
PTA have one of those, right?
Yep. Okay. Burn depth. Burn depth and wound depth are very similar. Okay. And you need to be able to stage a wound and be able to describe burn depth. These are some ways, and you don't need to write any of this down. These are some ways that they determine burn depth. But basically, it's what structures are remaining in the burned area. There's still hair there. You know, there's a certain depth. If they have feeling, that's different than if they don't have feeling. If it doesn't even hurt, you're in real trouble. That means they're below the dermis. Okay. Okay. So how do you determine it? If you splash grease on yourself and you have a pretty good burn, and within 3 weeks it's all healed, you had a superficial partial thickness. 21 days is the magic thing. You know, if it's going to take longer than that to heal, they evaluate the size of it to see if maybe you need a skin graft. Okay. But mostly you and I will heal from our bad sunburn or our curling iron burn or our straightener or our kitchen burn in 21 days. Okay. But the old second degree burn, which is now called partial thickness, is tricky because the deep ones don't heal in 21 days, but the superficial ones do. And when you get burned, you don't really know what it is yet. Like, it doesn't look like a nice little picture. As well as a wound. If a patient has a pressure ulcer, you're not really sure how deep the wound is, okay? The old words were first, second, third degree burns, okay? And that's not what we use now. So on your chart, you have four grids there. We're going to add, the first burn depth is superficial. Write that in. And then the next two are partial thickness. We're not going to include subdermal here. So you got superficial partial thickness, and number 3 will be deep partial thickness, and number 4 will be full thickness. Yep. So the first box here is going to say superficial. The next box is going to say superficial partial thickness, and number 3 will be deep partial thickness, and then full thickness. And so again, what's the equator on this one? It's that partial thickness. It's like if it's superficial, it acts more like a first degree or a superficial burn, like a sunburn or something like that. If it's deep, it's going to act more like, a third degree or full thickness burn, where there might be grafting necessary, or at least you're going to have scarring. Okay? All right. Some things you want to put in your boxes. For superficial, the color. The color is going to be pink or red. Think of a sunburn. What happens when you're sunburned? It's pink or red. The moisture, it's going to be dry. So just put dry in that box because the skin isn't broken. This is the same for like a stage 1 wound as well. Pain or sensation, it's delayed pain. If it was right away, we'd get out of the sun earlier. So you wake up and you're like, oh crap, so it's delayed pain. Healing and scar formation, healing in 3 to 5 days. No scar. Okay? Good on that one? All right, let's go to the superficial partial thickness. The color is going to be the pink red, or it could be mottled, M-O-T-T-L-E. What does mottled mean? Blotchy, white and red. Okay, so it's mottled or pink or red. Now for the moisture, it is moist, weeping or glistening. You know why? This is the blister burn, right? Blister in there. This is the blister that pops open. You've all had that. Pain, yep. It's painful. And you wouldn't want to put heat on it again for a while, right? If someone has blisters on their back, you're not going to put a hot pack on their back. And then healing, it will also heal itself, minimal scarring. Probably 21 days. Okay? So
for that one, the book says 5 to 21 days.
Yep, so it'll be healed by 21 days. If it's more than that, it was probably a little deeper. So 5 is the end of the first phase, like that first kind was 3 to 5, so this one will be 5 to 21. So in this kind of burn, you still have hair follicles because you didn't go that deep yet. So if there's still hair there, it's one of the things they look for. Okay, so it looks kind of bad, but it's not awful. Okay. Okay, now deep partial thickness. The color, now you're looking at possibly waxy white, so red and white. And now it's going to look nasty. Moisture, yes, it's still moist. Pain, actually, no. Insensitive, it says to light touch. Yeah, so now the nerve endings are messed up. But remember, if there's different levels to this burn, and there's areas of the burn that aren't this deep, those hurt. So there'll be areas where it's numb and areas where it's painful. This may need closure, and it may cause scarring. So this is a pretty intense burn. If it's larger than a size of a quarter, they're going to probably want to skin graft it or something. It may look like that. Okay. Last one, full thickness. Yeah, all kinds of colors because you have charred that skin. Now we're not into the muscle yet. We're still skin, but the skin is gone. Okay. It is dry, and it's going to require some type of primary closure. So yes, you're going to have scarring. Yep. Yep.
There are times when they, I know you said that you can wait 21 days to figure out if they need a skin graft. There are times when they go straight to the skin graft, correct?
If it's obvious, like let's say the whole front of the chest is burned off, they probably won't skin graft before 21, only because it's going to take that long to clean that wound out. But by 21, some areas might have healed, and now they can actually see what they need to graft.
So, for example, that bicycle accident, I'm sure they just wrap it in Band-Aids and let it rock, or do they
So the scapular one was daily shift bandage changes, bandage changes, bandage changes, because it didn't look like that when they came in. They had, road rash, and like that's probably weeks into care. Mild debridement, enzymatic debridement, where you put chemicals and like wet to dry padding, and every day they take it off, get the gook off, clean it gently, maybe not whirlpool it, but clean it, and continue to do that. And maybe even had to do some debridement because all the burn stuff had to come off. You can't have any yellow, green, white, nasty stuff left. It has to be all pink before you want to close that up. Yeah. 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 Now, where you might have primary closure right away is more of a laceration or a wound versus a burn. So if you just like rip your thigh open on something, yeah, they could clean that up probably within a few days and then sew it back on, but you still have your skin. So closure of a laceration would be a lot quicker. Yeah. Yeah. Okay. I have a picture of somebody laying on their left side. Their head is at the top. It's not their butt. That's their head coming down the spine because that was the deepest structure burned. But you can see that, and I'll show you this picture. It just depends on where at. Like there's all different levels of burn are on this patient. Okay. Okay. So I did want to give you that chart. Now, as far as the wounds go, similar but different. Okay. Someone find your chart on wounds, stages. Probably close to the burn page.
Pressure injury staging?
Yeah, pressure injuries would be good. Not coming over now.
Or 447 is wound classification by depth of injury. Oh, you said that. Okay.
Yeah, look for wound stages, pressure ulcers if you.
Pressure injury staging.
Yeah, pressure injury staging, good.
448.
Huh, my screen isn't coming over this time. So what's a stage 1 wound?
Non-blanchable.
Erythema.
Yep, thank you. Intact skin. 448.
What's non-blanchable erythema mean? It's red. They were laying on their back. Their tailbone is red, and you push on it, and it doesn't white out on you. You know how you normally can do a capillary flush? It just stays red. So it's like a sunburn from pressure. So the stage 1, you catch that, and so let's say your patient has been sitting in their wheelchair, and there's some lateral supports, and it puts pressure on the side. You get them back in bed. you're going to have redness where those lateral supports were, right? But how long until that redness disappears? On a healthy, normal skin? Minutes. 5 to 10 minutes. Yeah. A push, 5 to 10 seconds for fill. But if a patient's been sitting against a pad, or they have an AFO on and it makes their the heel red, or a brace, several minutes, you go back and look, it should look normal. If you or I wore something, it's going to be red where we were wearing it, but then it should go away. What about stage 2?
Partial thickness skin loss with exposed dermis.
Sounds like a blister pop to me, right? So a stage 2 is partial. Now there's a little skin missing, right? This is where the nurses will start to put some protective bandage on it. This could be from shearing, dragging them across the sheet, which is going to be more than just a stage 1. You might actually do some friction, some shearing, which is actually kind of a burn and a wound. What about stage 3?
Full thickness.
Full thickness. You have such a risk of infection for that person because now their barrier to infection is gone. What structures are visible, does your book say? Okay, so full thickness in this case for wounds means the skin is completely gone. Now you're looking at the fat tissue and
granular tissue and adipose rolled edges are often present.
Yeah, this is a pretty deep wound. Again, yeah.
This is like tunneling may occur, fascia, muscle, tendon, ligament, cartilage, and or bone are not exposed though.
Yeah, so that's going to be your stage 4. Stage 4 is you can see the bone.
What's slough again? It says if.
Yes.
Slough or eschar, but what's
Okay, so slough is the stringy yellow stuff that needs to get sprayed off, and eschar is the black. It all has to, if it doesn't look pink like a fresh steak, it's not ready to cover yet. It's infection. It all has to come off. Even your kid's skin knee with the scab. Once the scab pops off or whatever, you don't want to close that up. You want to keep that clean. I'm not saying don't put a bandage on and protect it, but you want to make sure that that heals. If they really rip a wad of skin off, make sure that the skin doesn't heal quickly over the top and you feel like there's depth underneath that's not been healing from the inside. You need to fill that hole from the bottom in and the outside in.
Is that what causes scarring?
The scarring is from it being deep and healing on its own, and the skin actually contracts and it doesn't have the same elasticity that the original did, yeah. Now, here's where you come in play. We can use ultrasound and electrical stimulation to promote skin healing in combination, pardon me, I'm tired, with the nursing department. And so maybe they're changing the bandages and then we're applying the electrical stim or that.
Like around the wound?
Yeah. There's something called a current of injury. So our body works on electricity. And where there's interrupted skin, the current changes, like the volts change. We can actually, so here's how electrical stim works. If it's a dirty wound and it's attracted to, let's say it's a certain bacteria, and it's attracted to positive pulse, we will put a positive pulse on it and repel it.
I remember this now.
If we are trying to get skin to grow in and we're trying to say, come on, the water's warm, we will put a negative pulse to try to attract the skin cells and the granulation. We can also use ultrasound around the perimeter for cavitation and streaming just to improve permeability of the cells and nutrition around the area. So something that's a mild pressure sore, I've done ultrasound. It's a very low pulse, like 20% pulse. It's very low pulse, 20% duty cycle. And if you want to know the protocol, you Google it. You look it up on research, not Google. But you'll look it up in the practice patterns and you'll talk to the PT and find out what current evidence shows for this type of wound at this whatever, and then you'll just apply that to the wound. Okay?
But like stage 3, can't you use the wound vac?
You may, so in a wound vac, good question. So you would apply that wound vac when you're trying to clean out a nasty wound. And when there is moisture and drainage, you're sucking all that out and keeping that thing clean from settling like a swamp. You want to keep that coming out.
So it is stage 3, like she said, right?
If there's drainage. If it's a dry wound, because there's poor vascularity or they're like a diabetic or it's like arterial too, it's an arterial wound from like, you're not going to have all that drainage. It's going to be dry. So by the time they dig out the dead stuff, you might be down to the bone. That's why when you have a gangrene toe or a heel ulcer, you end up being amputated below the knee or above the knee, because that's the most viable remnant. I had a lady go to the hospital with a black toe. She came back with a above knee amputation because there was no vascular integrity in the tibial artery, iliac artery. I mean, she came back with no leg at all. Yeah, but she was an arterial wound. So that's different than a traumatic wound on a healthy person. So you have to look at those things. Okay? So for stage 4, obviously they might need a skin graft or, very slow healing, but it's probably going to leave a scar. All right, now let's say they're a stage 3 and a month later now it's all healed up. It's just a little bit pink. What stage are they? It's a trick question. You never backstage a wound. It's a healing stage 3. Don't miss that one, right? You don't backstage a wound. If they were diagnosed as a stage 3 and now they're healing, whatever it looks like, they're a healing stage 3 with non-blanchable erythema, but they don't become a stage 1.
They can only be upgraded, but not downgraded.
Yeah, it can worsen. Yeah. But don't fall into that trap. They can't get that one past you guys. Okay. Let's see if I can slide this over.
It'd be the healing stage. So if they had a stage 3, it'd be a healing.
Chris, I can't get this to slide. What am I doing wrong? Trying to slide one of these screens over. The one that's all
It's probably not connected yet.
It thinks.
What it is.
What's that? Yep, we're going to get there. Okay, the stuff on the back is samples of the way that questions are posed to you, like things that you need to look at. This came from your critical work activities. You see the parentheses, and then there's things that you would collect, like, and just understand friction, shear, pressure, and scar mobility. Skin characteristics, wound characteristics, tissue depth, tunneling. We just did all that right now. Okay. Anybody know what that word is? Turgor? If you don't water your plants, they've lost their turgor. It's like pressure. So it's the bounce back in your skin. So if you're dehydrated and old like me and you pull your skin up and it just stays up there for like a week, I probably need to drink some water. But we know I'm not going to. I drank a whole bottle last night. Denise goes, "Did you drink your water?" I said, "I thought so." Nope, haven't opened it. I thought in myself, I need to drink water. But yeah, I have low turgor in my skin because it just sticks up there. It's not fluffy like a baby's butt, okay? Good. Okay, so those are some things that you can look at. Lymphedema, last one on there. You know your lymphedema types. Pitting, weeping, brawny classification, 0+, 1+, 2+ edema. Look up your edema classifications. Primary versus secondary. Lymphedema. How do we get rid of lymphedema? We wrap it We take them to the lymphedema person who knows how to do that funky little hairy fairy soft lymphedema massage that looks like they're not doing nothing. Like, woo, let's just do this. What they're actually doing is you have lymph nodes everywhere, right? Proteins and junk get stuck near the collecting ducts. It's like hair in the shower. All you have to do is move the hair, the water will go down. So it's not a milking massage with lymphedema. You're just moving the hair. So when you see these lymphedema specialists, they're just doing this little, and they might even look like they're going the wrong way. You're like, you're going the wrong way, because it's not a milking massage. They're actually clearing the collection portals. They're moving the hair out of the drain, and then magically after they elevate and they do some wrapping, this person comes out half the size. And they're like, I told you it was water weight, right? And you're like, yeah. So that's that. So you need to know the lymphedema numbers. Like there's 1 + 2 +. So similar to the pulse. So look up your lymphedema. Okay? So again, integumentary seems to trip people up, and the lymphedema stuff trips people up. There's no need for that to trip you up. Okay, home stretch. I wanted to show you what the critical work activities show you about the research stuff. So what is reliability and what is validity? Who wants to do reliability? You've heard of it, right? Reliability is retester. If I measure knee range of motion on somebody and you measure knee range of motion, like 2 minutes later, will we get the same answer? It's retester accuracy.
I literally know that because I got that answer wrong on the question because I didn't know what that was.
Okay, reliability is, okay, so there's intertester and intratester.
Yes.
If I measure you now and I measure you later and your knee range didn't change, but my measurements did, I have terrible intratester reliability. Like I can't even measure the same twice. If I measure you and Caitlin measures you and she gets a different answer, we have poor inter-tester reliability. You could both be wrong, but we're not consistent. So reliability is consistency, whether within myself or with different people. When it comes to integumentary and you're doing circumferential measurements with a tape measure, there's horrible reliability. Why? I don't know how hard you're squeezing that tape measure. I don't know if you lined it up with that mole or that freckle. Like, where were you at? So you have to really document 2 centimeters superior to the, border of the patella. Like, you have to really document where you're measuring. So some things don't have good reliability. Validity means you're actually measuring what you're supposed to. So that validity means when I say this is 90 degrees, that it's actually 90 degrees. If I were to use this ruler here, and I put that somewhere and I put it on the 15, I say, that's 15 degrees. No, it's not. It's 15 centimeters. Digital scales. How many of you use a digital scale? You get on it 2 different times in the same minute and it gives you 2 different answers. It's, yeah, of course. But so for one thing, that scale doesn't have good reliability. It's not consistent. But is it measuring in pounds or kilograms? So the validity, is it actually measuring what's supposed to measure? This measures joint motion, okay? It doesn't measure linear length. So validity is it actually measuring what it's supposed to measure, okay? Does an IQ test actually measure IQ, or is it measuring visual spatial coordination? I don't know. You know what I mean? So you have to know validity versus reliability. A couple other things that might pop up. Probability of things happening. So if you have a coin toss, heads or tails, what's the probability of getting heads? 50-50. What if I flip it twice? How do you know that? You are right. When you have probability and they give you 2 different percentages, you multiply them. You don't average them. This is used in medical fields, like the probability of a certain thing happening. So I'll give you a very personal example. I had breast cancer, both sides. I had 2 different tumors at the same time. So they did all their tests, we did all that stuff, and they said, okay, on this side you have a probability of 90% non-reoccurrence. And on the other one, it was 80% non-reoccurrence. Flip the other way, you have a 10% chance of reoccurrence and a 20% chance. So my combined probability was not 15%. It was like, well, 10% is not a good one because a 1 is a weird number. Let's say 15. Let's say 15 and 20. So my probability, instead of working with an 80 and an 85% survival, it was less than both of those because the 2 probabilities working against each other. Okay, so it's like 72% probability of survival. Okay, so if they give you a coin toss example and you have a 50% probability, but they're going to flip it twice, what's 0.5 times 0.5? 0.25. So that's where you came up with 25%. So if they give you 2 probabilities, just multiply them together. And if it's something you can do in your head, they're going to give you easy numbers, like a 60% and an 80%. It's not 70% if you put it together. It's going to be 48%. 60.6 times 0.8. Okay? Yeah. So if they give you a probability, I don't know, did you see a probability question? Okay, there's the answer. Was it coin toss? Okay, I did not just tell you that. Strike that from the record. Okay, so you multiply probabilities. And I'm like, well, that sucks. I like to average them better. I'm talking about survival here, but whatever. That was 12 years ago. All right. Okay, so prediction rules. I had to look this up while on the break because that's not a term I'm familiar with. So I'm hoping I can get to this other slide right here. So I did what everybody does. I go to ChatGPT. Okay, so I said, okay, so here's what we're going to, the way that the physical therapy profession does their stuff is it's new language to me. So a clinical prediction rule is just basically evidence-based practice. How do you know to treat a person with a herniated lumbar disc with extension? It's a clinical prediction rule based on what makes them feel better, what makes them feel worse, right? There's different ways to classify it. So it could just be, how to diagnose something. Well, that's literally how PTs diagnose. It's a clinical prediction. Now, I said, yes, give examples in PT. So there's all kind of different, it's all the special tests we do, okay? It's all that stuff. How a person's going to improve, okay? What do we prescribe for them as far as what we do? So don't get fooled by this terminology, clinical prediction rules, or patient preference clinical practice guidelines. If you go to the APTA website and you go to clinical practice guidelines, it's a whole database of things. How do we come up with these? We do case studies, we do randomized clinical trials, we try 100 people on this procedure and 100 people on a placebo, and then what do we find out? If the clinical intervention was actually better statistically than the placebo. So a couple things about research is statistical significance. Was there really a difference between the 2 groups, the hot pack group and the non-hot pack group? Or could it have just happened by chance? Well, there's statistical analysis that you do to determine that. Is it true that people with blue eyes do better at this than brown eyes? Or was it just a coincidence? And so you do statistical analysis to determine that. Okay? So know your basic evidence-based practice and things. What's the highest level of evidence? Would be a randomized controlled study. And even better than that is a meta-analysis of a whole bunch of randomized controlled studies. What's at the lowest? Expert opinion. But that's still something. It's still something. Above that, a case study. Above that, a comparison group. Okay? So just levels of evidence. Okay? Professional responsibilities. Know when to follow chain of command, right? You don't first go to the nursing home administrator if you haven't even gone to your supervising PT. And if the supervising PT is the problem, you go to your department director. Like, understand basic professional responsibilities. Who can you delegate to and who can you take instructions from? Okay? If there's a question scenario about you happen to witness something, let's say you walk in and someone is talking very abusively to a patient. Maybe it's a nurse's aide, not to pick on them. And they walk out. What is the first thing you do? The first thing you do is not go tell the supervisor or confront them. You attend to the patient. So when you get a scenario like that, you first will attend to the patient. Okay, it's like the gate belt one. Yes, you're going to tell somebody. You first attend to the patient. Okay, in case that's a scenario. Then you go punch out the person that was doing it. Yeah. Okay? All right. I hope that has been helpful. I know you guys have some time before your test, but as you can see, if you simply put one textbook on your schedule for a week, it will take you all that week to get through that textbook. But if you continue to condense your study materials and you write them out, you're going to learn it. Okay? All right. Thank you so much. You guys have done a great job.